Welcome back to the deep dive. Today we're doing something a little different. We're stepping out of the library and right into the fire.
Oh, I know this feeling.
Yeah, I want you to close your eyes and imagine it. The fluorescent lights are humming, the air conditioning is just a bit too cold, your palms are sweating.
And you're sitting across from 4 examiners.
Yeah.
2 internal, 2 external.
Yeah.
It's a nightmare scenario.
It is. We're turning the studio into a high-stakes coaching session, specifically for the MD anesthesiology exams.
And for our listeners, this isn't a nightmare. It's the reality they're prepping for. It is absolutely crunch time. And frankly, we're not just talking about passing here.
No.
We're talking about mastering one of the most critical, high-yield topics in the whole curriculum.
We're going to dissect a 20-mark long answer question that could, decide your fate on exam day. Pulmonary embolism and fat embolism syndrome.
PE and FES, the heavy hitters.
The dreaded PE and FES. I feel like this topic is the bane of every final year resident's existence. It's just so massive. The physiology is complex, and if you get stuck on a table viva with this, it can go south very, very quickly.
It can.
So here's the plan. I'm going to be the stressed out candidate. I've got my stack of books here. I'm looking at Miller, Morgan, and McConnell, Harrison's, and of course those dog-eared ICU protocols we all live by.
Essentials.
But I need you to help me synthesize all this. If I get that question, describe the etiology, pathophysiology, and management of pulmonary embolism. Where do I even start so I don't look like I'm just guessing?
It's a really common fear, but we are going to dismantle it today.
Yeah.
The trick isn't just memorizing lists. It's about understanding the story.
The story.
Specifically, the story of the right ventricle. If you understand the right ventricle, you understand PE. But before we get to the heart, pun intended, we need to structure your answer. We'll break this down into 4 parts, just like you would on your exam paper. Part A is pulmonary embolism. Part B is fat embolism syndrome. Part C is the comparison, which is absolute gold for Vivas.
Love a good comparison table.
And Part D is how to package it all up for the examiners.
Perfect. Let's dive into Part A, pulmonary embolism. Let's start with the introduction. For the exam, I can't just say it's a blood clot in the lung, can I? That feels way too basic for a postgraduate level.
It is too basic. You have to be precise. You define it as the obstruction of the pulmonary artery or its branches by material. And here's the key: that originated elsewhere in the body.
Okay, so not just a clot.
No, and you should immediately broaden the scope. Yes, it's usually a thrombus, but you have to mention air, fat, amniotic fluid, even septic emboli. That shows the examiner you're not just thinking linearly, you see the bigger picture.
Right, the great masquerader. And I suppose I need to drop in some statistics to show I've done the reading.
Exactly. Context is everything. You want to highlight that this is the most common preventable cause of hospital death.
That's a huge statement.
It is. In hospitalized patients, the incidence is around 2 to 4 per 1,000. And for us, in anesthesia, you zoom in on the maternal data. It's a major cause of maternal mortality.
Oh, major.
We're talking something like 15 to 25% of all maternal deaths. If you open with a fact like that, the examiner sits up. They know you understand the gravity of this topic.
Okay, gravity established. So the next section in a long answer is usually etiology. And I feel like if I don't say Virchow's Triad in the first 30 seconds, I fail on the spot.
You absolutely must mention Virchow's Triad. It is the cornerstone. But here's the tip. Don't just list it. Explain it in a way that's relevant to anesthesia.
Okay, so the first element is endothelial injury.
Right. And what does that mean in our world? It isn't just atherosclerosis. This is your trauma patient. This is the central line you just placed, the surgery itself. Every single incision triggers inflammation and injures endothelium.
That makes sense. Then the second element is stasis,
which is huge for us. Immobility for more than 4 days, obesity, congestive heart failure. And think about the pregnant patient again. The gravid uterus compressing the inferior vena cava.
That's just pure mechanical stasis.
Pure mechanical spaces. And then there's the third one.
Hypercoagulability.
This is where you can really pick up extra points. You mentioned malignancy, of course. But then you should also drop in the genetic factors.
Like factor V Leiden.
Exactly. Factor V Leiden mutation, which causes resistance to activated protein C, or you can mention deficiencies in protein C, protein S, or antithrombin III.
And I should probably mention oral contraceptives, too.
Precisely. Now, you have to connect it all back. Why do anesthetists care so much? Because our environment, the operating room, is a perfect storm for this triad.
How so?
Surgery lasting more than 30 minutes, the use of a tourniquet, specific positioning like the lateral decubitus. We are, in a way, manufacturing Virchow's Triad right there in the OR.
That's a terrifying thought, but a really good way to frame it. Okay, let's move on to the scary part for me. The pathophysiology. This is the core of the exam question.
It is.
It's a blockage, I get that. But why does the patient actually crash? I mean, what's the mechanism?
This is where we separate the pass from the honors. The crash happens because of two main things happening at once. A massive VQ mismatch and what I call the death spiral of the right ventricle.
Okay, let's unpack the VQ mismatch first.
So you got this clot blocking a pulmonary artery. The alveoli in that lung section, they're still getting air, right? The ventilator's pumping away.
Right ventilation is fine.
But they aren't getting any blood. There's no perfusion. We call this dead space ventilation. It's an infinitely high VQ ratio.
And that explains why, if I'm watching my monitor, I might see a sudden, sharp drop in end-tidal CO2.
Exactly. The CO2 in the blood simply can't get to those alveoli to be exhaled. It's trapped. So your EtCO2 plummets. But at the same time, the blood that would have gone there gets shunted to other parts of the lung.
Causing a shunt and hypoxemia?
Yes, you get hypoxemia from shunting and from atelectasis due to a loss of surfactant. But here's the critical concept, the thing you have to stress in your answer.
What's that?
The hypoxemia is rarely what kills the patient initially.
It's the heart.
It is the right ventricle. You have to understand the RV is a WIMP. It's a thin-walled, volume-handling chamber. It's just not designed to pump against high pressure.
And a massive PE is the ultimate high-pressure situation.
The ultimate. The pulmonary vascular resistance, the PVR, it just skyrockets. The RV has to push against this massive afterload, and it just can't. So it dilates. It gets huge.
And because the heart is inside the pericardium, there's not a lot of extra room. So if the RV gets huge...
The interventricular septum bulges to the left. It bows into the left ventricle. It is called ventricular interdependence. And that bowing physically prevents the LV from filling properly.
So it crushes the LV's preload.
It crushes it. And if the LV can't fill, it can't pump. Your cardiac output plummets and your systemic blood pressure crashes.
Wow. So the hypotension isn't just because blood can't get through the lungs. It's because the LV is being physically squashed by the failing RV.
Correct. And it gets even worse. This is the death spiral part.
Okay.
Systemic hypotension means you have low aortic pressure. The coronary arteries, which feed the heart muscle itself, are filled by that aortic pressure. So the supply of blood to the heart is dropping.
But the RV is working harder than it ever has, so its oxygen demand is through the roof.
Exactly. High demand, low supply. And there's another twist. Normally, the thin-walled RV gets blood flow during both systole and diastole. But when the pressure inside the RV gets super high, it can only get perfused during diastole, just like the LV.
But the patient is in shock, so they're profoundly tachycardic.
And tachycardia shortens diastole. So you have a high-demand RV with less time to get fed and a lower pressure feeding it.
The RV becomes ischemic.
The RV becomes ischemic. It fails even further. Cardiac output drops more. The blood pressure gets lower, which makes the ischemia worse. And the spiral continues right down to PEA arrest or a systole.
Wow. Okay, the RV death spiral. I'm definitely writing that down as a header in my answer. That clarifies so much about the management, which brings us to clinical features. What does this look like?
Well, the classic textbook triad is sudden dyspnea, pleuritic chest pain, and hemoptysis. But you should mention that hemoptysis usually means there's been a pulmonary infarction, which is actually less common.
What's the most common sign, though?
The most consistent sign is just unexplained tachycardia.
And for the exam, we absolutely have to distinguish between massive and submassive PE, right?
Yes, and this is a classic Viva trap. Massive PE is defined by hemodynamics, not the size of the clot.
Okay, so what's the definition?
It means the patient is in shock. Systolic BP less than 90 millivary Hg or drop of 40 millimilli Hg from their baseline for more than 15 minutes. That's a massive PE.
Got it. And submassive?
Submassive PE means the patient is normotensive, their blood pressure is okay, but they have evidence of RV strain.
Like on an echo or with raised cardiac biomarkers like troponin?
Exactly. RV strain, but stable BP.
Okay. Massive equals shock. Submassive equals strain. Now, the anesthetist's nightmare. I'm in the OT, the patient's under GA. They can't tell me they have chest pain. How do I spot it?
It's subtle and sudden. You'll see unexplained hypotension and tachycardia that isn't responding to your usual treatments. But the real giveaway, as we talked about,
that sudden drop in EtCO2.
the sudden, profound drop in EtCO2. You might also hear a new wheeze.
Wheezing.
Why? Bronchospasm. The platelets that are aggregated in the clot release mediators like serotonin and thromboxane A2, and these can constrict the airways.
Okay. I suspect it. How do I prove it? Diagnosis.
For the theory paper, you start with the ECG. You have to mention the classic S1Q3T3 pattern.
A deep S wave in lead 1, a Q wave in lead 3, and an inverted T wave in lead 3.
Yes, the examiners love that one. But then you have to add the caveat that practically it's pretty rare.
So what's more common?
Sinus tachycardia. That's number
Yeah.
one. Or you might see a new right bundle branch block. T-wave inversions in the anterior leads, V1 to V4, are actually quite specific for RV strain.
Okay, what about imaging?
The gold standard, your definitive answer, is a CT pulmonary angiography, or CTPA.
But what if my patient is crashing on the table? I can't exactly wheel them down to the CT scanner.
No, you can't. And that's where you say, for an unstable patient, the investigation of choice is bedside transthoracic echocardiography. Poor CS to the rescue.
Right. And what am I looking for in the echo?
You're looking for that big, dilated, failing RV. And if you really want to impress the examiner, you mention McConnell's sign.
McConnell sign. Break that down for me.
It's a very specific pattern of RV wall motion abnormality. The RV free wall is akinetic. It's barely moving, it's stunned, but the apex of the RV is still contracting vigorously.
So the apex is spared.
The apex is spared. It has this characteristic sort of winking appearance. It's highly suggestive of an acute PE as the cause of the RV failure.
Brilliant. Okay, last part of Part A management. We've diagnosed it. The patient is crashing. ABCs are a given. High flow oxygen. Intubate if you have to. But let's talk hemodynamics. There's a big trap here with fluids, isn't there?
A huge trap. It's the number one mistake. Your first instinct when a patient is hypotensive is give fluids.
Right, a big bolus.
But remember that bowing septum. If you flood a failing RV with more volume, you just distend it further. You worsen the septal shift, you crush the LV even more, and you can precipitate a full-blown arrest.
So fluids, judiciously. Maybe a small challenge of 250 mils.
Extremely judiciously. You want to maintain just enough preload, but not overload. You move very quickly to vasopressors.
And the drug of choice is norepinephrine.
Norepinephrine is your friend here. It has alpha agonist effects that raise the systemic blood pressure, which is critical for perfusing the coronary arteries and feeding that ischemic RV.
And it has some beta agonist effects, too, for contractility.
A little bit, yes.
Yeah.
You might also add a pure inotrope like dobutamine or milrinone to help the RV squeeze, but you have to be careful because they can cause vasodilation and drop the blood pressure further.
Okay. And then treating the actual clot.
The foundation of treatment is anticoagulation, heparin. In the perioperative setting, we prefer unfractionated heparin because its effect is short-lived, and we can reverse it quickly with protamine if there's bleeding or we need to operate.
And what's the trigger to use thrombolysis?
Thrombolysis is reserved for the hemodynamically unstable patient.
So for the massive PE.
Only for the massive PE. If they are dying from obstructive shock, you exstructive shock. You donaphilize them. If they are stable, you just stick with anticoagulation.
And what if they're dying but have a contraindication to lysis, like they just had brain surgery?
Then you're in a tough spot. That's when you have to call for help and consider mechanical options like surgical or catheter-based embolectomy.
That's super high yield. That covers PE. I feel much, much better about that section.
Good.
Now let's shift gears. Part B, fat embolism syndrome, FES. This always feels like the little sibling to PE, but it comes up in exams all the time, especially in ortho cases.
It does. And the very first distinction you need to make for the examiner, right in your introduction, is the difference between fat embolism and fat embolism syndrome.
They're not the same thing.
Not at all. Fat embolism, which is just the presence of fat globules in the pulmonary circulation, happens in almost 90% of patients with long bone fractures. It's nearly universal.
90%? Wow.
But most of those patients don't get sick. Fat embolism syndrome, or FES, is the specific clinical manifestation of multi-system dysfunction that results from that. And that only happens in about 0.5 to 3% of cases.
So just because you have fat in your blood doesn't mean you have the syndrome.
Got it.
The etiology is mostly orthopedic trauma, right?
Yes. The big offenders are fractures of the femur, tibia, and pelvis, especially in young patients with high-energy trauma.
What about during surgery?
Absolutely. Procedures like intramedullary nailing or during total hip replacements when they're reaming the femoral canal or pressurizing the bone cement, that can squeeze fat and marrow straight into the circulation.
Let's get into the pathophysiology. Why does a bit of fat make you so sick?
There are two theories you need to write down. The first is the simple mechanical theory.
Which is just that the fat globules are big and they physically block the pulmonary capillaries just like a blood clot would.
Exactly. It's a mechanical obstruction. But that theory doesn't explain everything.
Like the delay in symptoms.
Precisely. FES symptoms usually start 24 to 72 hours after the injury. That's where the more important biochemical theory comes in.
This is the toxic phase.
That's a perfect way to put it. The fat globules are broken down by lipases in the plasma into free fatty acids, or FFAs. These FFAs are directly toxic to the capillary endothelium, especially in the lungs.
So it's more like a chemical injury.
It is. The FFAs trigger a massive inflammatory cascade, a cytokine storm. It causes the capillaries to leak, leading to non-cardiogenic pulmonary edema. It basically causes ARDS.
So it's less about blockage and much more about inflammation.
Yes, exactly. For the exam, you should say that FES is better understood as a systemic inflammatory response, not just a simple embolic event.
That's a key distinction. Okay, clinical features. For PE, we had a classic triad. FES has one too, right? Gurd's criteria.
Yes, Gurd's criteria.
Yeah.
You absolutely have to know the classic triad. Number 1 is respiratory.
Hypoxia, dyspnea, looks like ARDS. This is usually the first sign to appear.
Correct. Number 2 is neurological.
Confusion, agitation, drowsiness, maybe even a seizure or coma.
And this is so important. If you have a young patient with a femur fracture who starts getting confused or combative 24 hours after their injury, you have to think FES. Don't just attribute it to a missed head injury or medication side effects.
Okay. And the third part of the triad, the one that's a dead giveaway.
The petechial rash. This is pathognomonic. It doesn't happen in everyone, maybe only 20 to 50% of patients. But if you see it, you've pretty much confirmed your diagnosis.
And where do I look for? Is it all over?
No, it has a very specific distribution. You look on the chest, in the axilla, the armpits, on the neck, and in the conjunctiva of the eyes.
And why does the rash happen?
It's thought to be from endothelial damage to the capillaries caused by those toxic fatty acids, leading to extravasation of red blood cells.
And the timing is key here. You mentioned the delay.
Yes. Here's where it gets really interesting. PE is usually sudden. Boom, it happens. FES has a lucid interval. The patient is fine for a day, maybe 2, and then they start to deteriorate. That interval is a key differentiating feature.
So how do we diagnose FES? Is there a blood test?
No, and that's a crucial point. It is a clinical diagnosis of exclusion. There is no single lab test that says positive for FES.
So what are the supportive findings?
You might see things like thrombocytopenia, because platelets get consumed by aggregating around the fat droplets, or an unexplained anemia. You might see fat globules in the urine or sputum, but that's not very specific.
And on a chest x-ray?
Diffuse bilateral infiltrates. The classic description is a snowstorm appearance, which is really just the look of ARDS. On a brain MRI, you might see a star field pattern of diffuse microinfarcts.
Okay. And management. What do we do for these patients?
It's purely supportive. There is no specific antidote or treatment. You are essentially treating multi-organ dysfunction.
So for the lungs, it's ARDS management.
Exactly. Lung protective ventilation, low tidal volumes, using PEEP. You provide good hemodynamic support with fluids and vasopressors as needed. Some people advocate for using albumin with the theory that it might bind the free fatty acids, but the evidence for that is pretty weak.
What about steroids? I remember reading something about their use in FES.
It is controversial. There's some evidence to suggest that prophylactic corticosteroids given early to high-risk fracture patients might reduce the incidence of FES.
And what about for treatment?
Also controversial, but sometimes used in fulminant cases to try and dampen that massive inflammatory storm. For an exam, you should mention it as a controversial but potential therapy.
So what's the most important thing we can do?
The single most effective preventative measure is early surgical fixation of fractures. Pinning that broken bone within 24 hours reduces the risk significantly because it stabilizes the marrow and stops the continuous leakage of fat.
Okay, we've covered Part A and Part B in detail. Now for Part C, the comparison, this is the section that gets you the extra marks, isn't it? If I can draw a neat table in my theory paper, the examiner is happy.
Examiners love tables. It shows you can synthesize information clearly, so let's build one right now, verbally.
Okay, let's do it. First up, onset. For PE, it's immediate, it's sudden.
Right. And for FES, it's delayed. You have that 12 to 72-hour lucid interval.
Next, pathophysiology. PE is fundamentally an obstructive process from a clot.
Whereas FES is fundamentally an inflammatory, toxic process from free fatty acids.
Good distinction. What about the skin? A patient with a massive PE is going to be pale, maybe cyanosed.
And the FES patient might have that pathognomonic petechial rash on their chest and axilla.
CNS involvement. In PE, you might get syncope from the sudden drop in cardiac output, or just anxiety from air hunger.
But in FES, the CNS signs are more primary confusion, agitation, a decreased level of consciousness.
And finally, the primary treatment target. In PE, you have to support the right ventricle.
And in FES, you have to support the lungs, treating it like ARDS.
That is crystal clear. Okay, let's do a quick intraoperative scenario. You're halfway through a cemented total hip replacement. Suddenly, the SATs drop and the blood pressure tanks. Is it PE or FES?
Great question. Intraoperatively, at that exact moment, you should be thinking about a few things. It could be a massive PE, it could be an air embolism. But you also have to think about bone cement implantation syndrome.
Ah, BCIS.
Right. When they pressurize the cement into the femur, it can cause a sudden embolization of fat, marrow, air, and cement particles. But it can also trigger a reaction to the liquid monomer itself, causing vasodilation and cardiac depression.
And that happens right at the time of cementation.
Exactly. The full-blown FES syndrome is unlikely to manifest fully intraoperatively because of that required time delay for the biochemical reaction, though the embolization event itself happens then.
So, if they crash on the table during an ortho case, think PE, air embolism, or cement reaction. If they crash 2 days later in the ICU, think FES.
That's a perfect way to summarize it.
Okay, let's move to our final section, Part D, exam integration. Let's wrap this up with some Viva traps and presentation tips. What are the common ways candidates fail this question?
The biggest trap, and I can't stress this enough, is the fluid management in massive PE.
The fluid bolus.
If you say your first step for the hypotensive PE patient is give a wide-open fluid bolus, you might fail that Viva station right there.
Yeah.
You must demonstrate that you understand the RV failure and the bowing septum.
Any other common traps?
Yes. In diagnosis, don't say a D-dimer confirms PE. A D-dimer is good for ruling out PE if it's negative in a low-risk patient. It has terrible positive predictive value. Only CTPA or direct visualization confirms it.
What about for FES?
For FES, the traps are forgetting the lucid interval or forgetting to mention the rash. Those are the hallmark features that differentiate it. Also, calling it just an embolic event when you really should be calling it an inflammatory storm.
Okay, and for the theory paper structure, how do I present this?
You start with a strong definition. You use clear headings. And you must use diagrams. Draw the RV death spiral as a simple flowchart.
So box 1 is obstruction, arrow to high PVR, arrow to RV dilation.
Arrow to septal bowing, arrow to low LV preload and low cardiac output, which then arrows back to RV ischemia.
Yeah.
That one diagram is probably worth 5 marks on its own.
And for FES, what's a good diagram?
Draw Gurd's criteria as a triangle. Put respiratory, CNS, and rash at the 3 points. Visuals break up the wall of text and show the examiner that you can structure your thoughts.
This has been incredibly high yield. I honestly feel like I could walk into that exam room now and answer this question without panicking.
You're ready. Just remember the core concepts. PE is all about the right ventricle. FES is all about the inflammatory storm. Keep those two ideas separate and clear in your head, and you will absolutely ace it.
Before we sign off, any final provocative thought? Something for us to chew on?
Here's one for you. We've talked about clots from the legs going to the lungs, but you need to remember the paradoxical embolism.
Okay.
If your patient has a patent foramen ovale, a PFO, which about 25% of the general population does, that clot from the leg can cross from the right atrium directly into the left atrium.
It bypasses the lungs entirely.
It bypasses the lungs entirely and goes straight up to the brain, causing a massive stroke.
Oh.
So if you have a young patient with a DVT who suddenly has a stroke, you need to think about a paradoxical embolism. You've just connected the venous and the arterial worlds.
That's a connection that would definitely make an examiner smile.
It absolutely would.
That is fascinating. The body really is all connected. Thank you so much for this incredible tour de force.
My pleasure. Good luck to everyone sitting the Gujarat University exams. Go get those 20 marks.
You've got this. This has been The Deep Dive. See you next time.